Hello everyone, Dr. Rajiv here. Welcome to my education channel, YouTube Surgery and Orthopedic Education. This video is next in my series of YouTube teaching video cast for undergraduate and postgraduate medical students. Today we shall discuss diagnostic imaging of a spinal cord injury. In the end, please subscribe to our channel and give us a like if you find the discussion useful. So let us not waste time anymore, and here we go. The unconscious or uncooperative trauma patient should be assumed to have a spinal injury until proven otherwise. Imaging is required to evaluate and confirm part-specific vertebral column injury. Diagnostic imaging traditionally begins with the obtaining of standard radiographs of the affected region of the spine. Although plain radiographs of the spine in a standard anteroposterior, lateral, odontoid or open mouth views are acceptable, but plain cervical spine radiographs fail to identify 15% of the injuries. The imaging recommendations for evaluation of cervical spine symptoms have changed in recent years. The principal imaging modalities for the evaluation of traumatic spine injury are computed tomography and magnetic resonance imaging. Neuroimaging techniques show the exact location of injury, evaluate the stability of the spine, and determine neural element compromise. The spine fractures separated by at least one normal vertebra are known as non-contiguous spine fractures. These fractures occur in 10 to 15% of patients with a spinal cord injury. Therefore, after a spinal fracture is identified, the entire spine must be imaged, preferably by CT scanning, to identify other non-contiguous fractures. This YouTube teaching videocast focuses on the role of different radiologic modalities in the diagnosis of patients with traumatic injuries of the spine. Anteroposterior and lateral plane X-ray films provide a rapid survey of the bony spine elements. Plane films detect fractures and dislocations well, but adequate visualization of the lower cervical and upper thoracic spine often is impossible because of the shoulder girdle. A common cause of missed spinal injury is the failure to obtain clear radiographic images of the cervical spine, particularly at the cervicothoracic and occipito-cervical junctions. The cervical spine is a common site of injury and often not adequately seen on a poor plane radiograph. The nexus criteria, that is, National Emergency X-radiography Utilization Study criteria, established guidelines for cervical spine radiography in symptomatic trauma patients with neck pain. A standard plane X-ray film imaging of the cervical spine includes anteroposterior, lateral, and odontoid or open mouth view to assess the odontoid process and the lateral masses of the C1. The cervical spine radiographs must include the C7-T1 junction to be considered complete. Subtle findings like increased prevertebral soft tissue swelling or widening of the C1-C2 pre-odontoid space indicate potentially unstable cervical spine injuries that may have serious consequences if they are not detected. Dynamic flexion extension views are safe and effective for detecting occult ligamentous injury of the cervical spine if there is no fracture. They can help assessing spinal stability in the longer term but should not be undertaken acutely because of the challenges associated with visualizing the cervicothoracic junction. Plane radiography and initial cervical spine CT scan is now often obtained in acute setting. Evaluate a lateral cervical spine radiograph properly. There should be a clear visualization of vertebral bodies, articular pillars, and zygapophyseal joints from C1 to T1. Assess prevertebral soft tissue swelling. The prevertebral soft tissue in front of C2 should be less than 50% of the width of the C2 vertebral body, and in front of C6 should be no more than the width of the C6 vertebral body. The spine instability is present if a lateral cervical spine X-ray shows an obvious sagittal angulation of more than 11 degree and a translation of more than 3.5. The gold standard diagnostic imaging modality in spine and spinal cord injury at present is the computed tomography scanning with two-dimensional reconstruction. It has been established as the diagnostic imaging modality of choice in injuries of the thoracic, lumbar, or sacral regions of the spine. A CT scan, either with or without contrast, is considered a non-invasive method of investigation. It is usually obtained as part of the primary workup in emergency department for suspected or visible injuries on plain radiographs. A patient of closed head injury should also be offered a CT scanning of the cervical spine. In polytrauma patients also, a screening CT scanning of the spine should be done apart from that of chest and abdomen. Helical CT is able to identify 99.3% of all fractures of the cervical, thoracic, and lumbar spine. Those injuries missed by helical CT requires minimal or no treatment. Magnetic resonance imaging or MRI of the spine provides the best imaging of soft tissue elements such as ligaments and disc material. MRI is most useful in patients whose CT scanning does not clarify the neurological status, that is, in a neurologically impaired victim with an unremarkable CT. Canal compromise from subluxation, acute disc herniations, ligamentous disruption, cord contusions, or areas of ischemia can be detected on MRI. MRI can detect a missed spinal column injury or neural compressive pathological processes such as disc fragments, epidural hematoma, or the presence of significant canal stenosis from other causes. MRI should be obtained if a patient has abnormal findings on CT suggesting soft tissue injury, such as soft tissue density anterior to the mid-body of C3 vertebra greater than 5 mm or a widened disc space of more than 1 to 2 mm at one level relative to adjacent disc levels.